We're right on 7 o'clock, so welcome everyone to the 2024 Koadlow Lecture. My name is Helen Jentz and I am the Chief Executive Officer of Musculoskeletal Health Australia. As we begin this evening, I acknowledge the traditional owners on the lands from which you are all joining us. We are streaming to you from the lands of the Eastern Kulin Nation and acknowledge the Boonwurrung, Bunurong, and Wurundjeri people as the traditional owners and custodians. We pay our respects to their elders past, present and emerging, and recognise and uphold their continuing relationship to the land and waterways. We also extend our respects to all Aboriginal and Torres Strait Islander people with us tonight. This evening's Koadlow Lecture has been made possible by the generous financial support of our sponsors, Peninsula Hot Springs and AbbVie. Please note, our sponsors have no input as to the theme or content presented this evening. Running now for over 15 years, the annual Koadlow Lecture is named in honour of Musculoskeletal Health Australia's founder, rheumatologist Dr. Les Koadlow. October is Musculoskeletal Health Awareness Month, and Musculoskeletal Health Australia has a full calendar of activities specifically focused on raising awareness about the importance of musculoskeletal health and the 150 plus musculoskeletal conditions that are one of the biggest causes of disability globally and negatively impact more than 7 million Australians. As part of this, World Arthritis Day is being held on Saturday, the 12th of October. The theme for 2024 is Informed Choices, Better Outcomes. In celebration of World Arthritis Day, the topic of this evening's Koadlow Lecture is lifestyle choices that can impact musculoskeletal health. Musculoskeletal conditions impose a huge personal and social burden, not only in Australia, but globally. Lifestyle choices like diet, exercise, and sleep can impact musculoskeletal health. The lecture this evening focuses on how these and other lifestyle choices can positively influence prevention and management of musculoskeletal diseases. Now, to our incredible lecturer this evening. Professor Rana Hinman is a physiotherapist, a professor, NHMRC Investigator Fellow, and Deputy Director of the Centre for Health, Exercise and Sports Medicine at the University of Melbourne. She has over 20 years of research and clinical trial experience in musculoskeletal pain, in particular, non-drug treatments for OA, as well as telehealth and digital healthcare approaches to increase access to care. She also serves on the editorial board of the Journal of Physiotherapy. Now, I don't believe this. Rana has over 350 publications, and that is absolutely 100% true, and has attained more than $35 million in research funding as a chief investigator. Please note the views expressed in tonight's lecture are those of our presenter. And now, welcome Professor Hinman.
Thanks very much, Helen, for that really lovely introduction. And thanks also to Musculoskeletal Health Australia for inviting me to deliver this lecture tonight, focused on lifestyle choices. And indeed, lifestyle choices, and in particular exercise, has been a major focus of my research career to date. And that's probably because I'm a physiotherapist by background, and as most people listening would be aware, exercise is a key component of physiotherapy care. Oops, sorry, I'll just take that back. I'm going to, just to give you a bit of an outline of what I want to touch on this evening, we'll start with a bit of background context, really, and Helen's given us a nice lead into the personal and societal burden of musculoskeletal conditions. Then I'm going to talk a bit more specifically about the role of exercise, followed by the role of weight management, as well as some other lifestyle factors to consider, and then finish up with what are the lifestyle recommendations for people with musculoskeletal conditions. Just to be upfront with disclosures and to let people know that my salary is partially supported by the National Health and Medical Research Council, and I do receive grant funding from the NHMRC, MRFF and Medibank for my research. And as Helen says, I'm on the editorial board of the Journal of Physiotherapy. Well, what are musculoskeletal conditions? They're conditions that affect the bones, muscles and joints and certain connective tissues of the body. And in particular tonight, I'm going to be focusing more on long-term or chronic musculoskeletal conditions, because that's really where lifestyle management really comes into having a major role. And long-term conditions, there's lots of them, but some of the big ones that we need to think about here are back pain and back problems, osteoarthritis, osteoporosis or osteopenia, rheumatoid arthritis, gout, and juvenile arthritis. These are some of the really common chronic musculoskeletal conditions that you may have heard of, or in fact, you may actually be living with. Now, in Australia, we know that 7.3 million, or about a third of Australians, live with a chronic musculoskeletal condition, and that's a really large number. About 4 million people have back problems. 3.7 million are living with some form of arthritis, and almost 1 million are living with osteoporosis or osteopenia. And this is data from the most recent surveys that the Australian government collects. Globally, it's an enormous burden. We know that 1.7 billion people globally live with a chronic musculoskeletal condition, and this creates a really big need for healthcare across the world. And the impact, the personal impact on an individual is enormous, and it really does differ depending on what the condition is. But some really common hallmarks of musculoskeletal conditions is pain, and it's often persistent pain, disability, limited mobility and dexterity. We know that people with musculoskeletal conditions often have to retire early from work because of their health. They often report lower levels of well-being, and all of these problems culminate in a reduced ability to participate in society and other activities that are meaningful to the person, including leisure and family activities as well. This is some, again, data from Australia, and I think it's really important when we're talking tonight about lifestyle conditions that, in fact, less than a third of people with arthritis only have arthritis only as a chronic health problem. What we find is that about 3/4 of people will have at least their arthritis and one or more other selected chronic conditions. And in fact, almost half of people living with arthritis will have 2 or more other chronic conditions. So there's this often termed comorbidity. And there's lots of conditions that these might be, but some of the big ones are problems such as asthma, back pain, cancer, chronic obstructive pulmonary disease, diabetes, heart, stroke and vascular disease, kidney disease, mental and behavioural conditions, and osteoporosis. And the reason I emphasise that these chronic musculoskeletal conditions often occur hand in hand with other chronic conditions is because lifestyle management is often common to all of these. And so when we talk about lifestyle management benefiting musculoskeletal health, it's often also benefiting the comorbidities that people with musculoskeletal conditions are living with. And if we have, this is just looking at health expenditure and looking at going from left to right, where healthy, areas of health expenditure in Australia, where we can see quite a large proportion there is on private hospital services, followed by medical imaging. And if we think about musculoskeletal conditions, we know that they rank as number 1 of all disease groups for private hospital expenses, and number 2 of all disease groups for medical imaging expenses. So musculoskeletal conditions are expensive. They don't just cost the healthcare system money, they also cost the individual who there's plenty of research with consumers telling us how expensive and what a financial burden it is to be looking after their musculoskeletal problem. So what is lifestyle medicine? Lifestyle medicine aims to support people to prevent and manage chronic health conditions using behaviour change skills and techniques to create and maintain changes in their lifestyle. And what do we mean when we're talking about lifestyle? Well, this figure shows you that there's, 6 key pillars to lifestyle medicine, including healthy eating, physical activity, sleep, minimizing harmful substances such as alcohol, tobacco, or drugs, healthy relationships, and mental well-being. And I've just highlighted in orange there the two lifestyle factors that I'll be focusing on mostly tonight, which is around weight management and healthy eating, and physical activity and exercise. We know that lifestyle risk factors are really big contributors to disease burden in Australia. And that's what this graph is showing you here, where we can see in those little boxes in red that I've highlighted, those are lifestyle risk factors and how the number of incidences of disease that they contribute to. So we can see that tobacco use, being overweight or having obesity, and other dietary risk factors are 3 of the top lifestyle risk factors. But also in there is alcohol use, illicit drug use, and physical inactivity as well. And so, as I've already alluded to, this is not just for musculoskeletal conditions, but also a lot of other chronic health conditions as well. And if we think about some of the musculoskeletal problems, such as osteoarthritis, it's really quite alarming to see that almost 1/3 of disease burden is due to overweight or obesity. If we look at the problem of back pain, we can see that 9 to 10% of disease burden is due to overweight and obesity, with a smaller proportion due to tobacco use. Gout, 31 to 40% of disease burden is due to overweight and obesity. And with rheumatoid arthritis, we see tobacco use also playing a role in disease burden. So really seeing lifestyle factors playing a part in multiple musculoskeletal conditions here. Now, it's important to recognise also that lifestyle management is not just about treating symptoms of musculoskeletal conditions once you have the problem, but lifestyle management can also help prevent musculoskeletal conditions in the first place, or slow down their progression or potential worsening over time. And I'm an osteoarthritis researcher, so I'm going to put up what I've put up here is just the example of thinking about osteoarthritis and all the possible opportunities we might have for preventing OA over the lifespan. And what we can see is that lifestyle factors have multiple opportunities where they might play a preventative role in OA. So, for example, if you look at that lower left-hand figure, over the entire lifespan, preventing overweight and inactivity can help prevent osteoarthritis. But we also know in those active adulthood years where people are active in sport, and sporting injury is a major factor for causing OA, preventing sporting injuries by sport prevention programs, which usually entail exercise, preventing muscle weakness and preventing injury, can also play a role in preventing OA. And then if we look down to the lower down here, hopefully you can see my arrow, we can see again that during the years of menopause, that preventing weight gain that often occurs in women during those years of menopause and the perimenopausal time can also play a major preventative role. And again, in the older years where we know that age-related muscle loss and muscle wasting that comes from that could also be prevented with lifestyle management such as exercise. So lots of opportunities for prevention if we think about the lifestyle choices that we make. Now let's talk a little bit more about the role of exercise. And we know that sedentary lifestyles are well known to be associated with non-communicable diseases like musculoskeletal conditions, but also other diseases such as heart disease, high blood pressure and stroke, diabetes, and as well as some cancers. And there's more and more evidence emerging all the time about the role of lifestyle factors and cancers. And so this often explains why some people have clusters of these lifestyle related conditions, and they coexist together. But we also know that sedentary lifestyles are associated with back problems and in particular with osteoarthritis and chronic joint pain. Now, if you think about sedentary behaviour and insufficient physical activity, some of the consequences of that are muscle weakness. And there's good evidence to show that having weaker muscles, particularly in the legs, in the quadriceps, is a risk factor for developing knee osteoarthritis, but also for worsening of knee osteoarthritis over time once you've developed the condition. So avoiding sedentary lifestyles and maintaining muscle strength can play a role in reducing disease incidence and disease progression. We also know that being sedentary and not getting enough physical activity leads to muscle weakness, and it can lead to becoming more frail and impaired cardiovascular system over time. And all of these can culminate in an increased falls risk. And we know that the more joints affected in people with osteoarthritis, the greater the risk of falls. And so, for example, over there on the right of the slide, you can see that people who have 3 to 4 joints affected with osteoarthritis have been shown to have an 85% higher falls risk. And what this, it's a bit of a busy diagram here, but it's really to highlight that it really is a bit of a vicious cycle of inactivity in osteoarthritis. So being inactive can lead to joint pain and fear of movement. It can lead to poor confidence in your ability to be active. It can compound any coexisting health conditions that you have and resulting fatigue, which leads to deconditioning and muscle weakness and impairments in balance. It can manifest or increase those effects of osteoarthritis, so making pain and fatigue worse, and as well as exacerbating those cardiovascular impairments, which all impact on reduced function and reduced exercise capacity, which lead to greater risk of musculoskeletal injury and disease and that risk of falls that I just spoke about. And also then an increased risk of becoming overweight or having obesity and a range of these other chronic health conditions that we've talked about that then feed again into leading to more physical inactivity, and so the cycle goes. And it's really important to think about where can we break this cycle. And so this is where lifestyle factors such as inactivity and increasing physical activity and participating in exercise can really help to break this cycle. And there's lots of research evidence to show that when people with osteoarthritis do become more physically active and undertake regular exercise, that there's evidence that it can improve physical well-being with improvements in joint pain, improved muscle strength, reduced stiffness in the joint and leading to increased flexibility and joint movement. All of this culminates in improved physical function and the ability to do those activities that are important to somebody. Joint stability feels improved, balance is improved, and quality of sleep and fitness can also be improved. But it's not just physical factors that are improved by being more physically active. We also see, or research has shown, improvements in emotional well-being, such as improved mood, reduced fear of movement, reduced feelings of being fatigued, and also decreased stress and anxiety. And this all culminates to improved social well-being, including the ability to participate socially as well as care for others, such as family members, and indeed yourself. We've also got increasing evidence now about the amount of physical activity and real sort of tangible thresholds about how it can improve health. And lots of you have probably heard about the magical 10,000 steps a day, which often feels really daunting. And I know I myself don't often get 10,000 steps a day. Well, that's really being debunked as a myth now. And we've got research evidence showing that as little as 6,000 steps a day actually protects against developing functional problems over time in people with knee osteoarthritis. And as little as 45 minutes of moderate to vigorous physical activity a week can lead to sustained or improved physical function over 2 years. So we're really starting to see the sorts of thresholds that can really help prevent functional decline and really maintain those high levels of functioning that people want to have when they're living with a musculoskeletal problem. We also have got some evidence from clinical trials showing that participating in exercise can help reduce the need of joint replacement over time. And this need can be reduced by 44% at 6 years in people with hip osteoarthritis, and by 68% at 2 years in people with knee osteoarthritis. And so that's really important data, because quite often people really want to avoid having a surgical joint replacement in future. And so the knowledge that not only can exercise and physical activity help your pain and symptoms and your functioning now, but might also delay the need or reduce the need for surgery in future, is often a really motivating factor for people to start to engage in lifestyle management. I'll just talk a little bit about a program that we developed and did research on at Melbourne University, which we call My Knee Exercise. And so we developed this as a web-based program built around 3 real pillars. So one pillar provides education about knee pain and knee osteoarthritis. This middle one is a 6-month programmed knee strengthening exercise program with instructions and videos for people to work through a knee strengthening program at home on their own. And the final pillar is around increasing physical activity with tips and guidance for how to do that. And supplemented by a range of different tools and exercise diaries to help people stick to the program. So that on the left here just shows you an example of an exercise in one of the programs with the photos and the instructions there. And we did a clinical trial in people with knee osteoarthritis, and we found that pain improved in the majority of people undertaking this exercise program, and also physical function improved. And importantly, this is a web-based exercise program that doesn't require a clinician. We know that accessing clinicians can be really challenging and financially draining for many people with musculoskeletal conditions, which is why we developed this web-based program. And this trial showed that it's effective. So this is something that is available online. And at the end of my talk, I'll put up some QR codes that links to that resource for anybody who's interested. What about weight management? Well, alarmingly, in Australia in 2018, we know that overweight and obesity contributed to 9% of the entire musculoskeletal burden of disease. And really alarmingly, almost a third of the osteoarthritis burden. And so if we can really tackle this problem of overweight and obesity, we'll not only be able to reduce the number of people who have OA, but also the people who are living with OA will find it impacts them to a much lesser degree if people are able to keep their body weight within a healthy weight range. And even for people who may not be able to achieve a healthy weight range, losing some body weight will help also improve symptoms. We know obesity, people often think about carrying extra weight as the absolute load it applies to the joints. And that is correct. Putting extra load, extra physical load on the joints is one of the reasons why being obese or overweight can contribute to musculoskeletal problems. But perhaps even more importantly, it's more to do with the chronic and systemic. So when I say systemic, I mean the whole body effect that being overweight or having obesity has on causing low-grade whole body inflammation, which can then increase the risk of local inflammation in musculoskeletal conditions, such as epicondylitis, which is tennis elbow, for example. And we know that overweight and obesity is associated with a range of musculoskeletal conditions that can also impact a person's ability to exercise and be functional. So particularly back pain, gout, and osteoarthritis. And another negative aspect of having a greater body mass is that we know that people with a greater body mass tend to have lower pain thresholds as well than people with a healthier body mass. So there's lots of reasons why lifestyle management and looking at weight management can really help break the cycle in chronic musculoskeletal conditions. Oops. Now, again, this is a little bit of a busy diagram, but if you look up at the top, it's really highlighting the interplay between not getting enough physical activity and the consequences of accumulating body fat that then leads to this cycle of chronic systemic inflammation that I've talked about, which feeds back locally to affecting the joints, causing pain and joint troubles, which then makes it hard to be active, can lead to more body fat and so on. We've got a little mini vicious cycle happening here. But we also know that many of these other chronic conditions that I've talked about, such as loss of muscle mass, we've talked about diabetes, they can also lead to or result in chemical changes that also lead to chronic systemic inflammation and feed into this cycle. So again, it's really emphasizing the link between lifestyle management and musculoskeletal diseases, but also these other chronic conditions that coexist with musculoskeletal problems that also feed into this lifestyle cycle as well. And so what we know, again, particularly with osteoarthritis, is that we know that when people with chronic knee pain or knee problems lose weight, we know that that can help prevent knee problems from occurring in the first place. And research has shown that for people who have knee problems or knee complaints, that as little as 5 kilograms or 5% of body weight loss can lead to a much lower chance of developing or having knee complaints 6 years later. So from a preventative point of view, again, weight loss is a really important factor for people who might be struggling with overweight and obesity to help prevent musculoskeletal conditions. But we also know that when people have already got developed musculoskeletal pain, that weight loss can really help those symptoms. And this is just a little infographic of a trial we recently completed in people with painful knee osteoarthritis, where we looked at how helpful it was adding a dietary weight loss program to an exercise-only program. So what we did was we took 88 people with knee OA and we randomized them to either a strengthening exercise program only here on the left, or on the right, they got the strengthening exercise program plus a dietary weight loss program, which was a very low calorie diet with meal replacements, followed by a transition to healthy eating. And this was a physiotherapist delivered intervention over 6 months. What we found at 6 months was that I'll just take that back because I've just accidentally clicked on that. We found that the diet and exercise program resulted in an 8% loss of body weight and a 5.5 centimetre decrease in waist circumference. And importantly, 71% of people in that treatment group reported improvements in their knee problems compared to only 48% of people who only had exercise. So to get the best bang for buck in lifestyle management, it really seems, or certainly with a lot of chronic joint pain problems, combining exercise only with dietary management will really maximize those benefits. Now, of course, weight management is not just about losing body weight or controlling body weight, but it's also about the role of nutrition. And because we know that if you're not getting enough micro or macronutrients in your diet, your ability to actually be physically active and undertake exercise will be compromised. We also know that nutrition is really important for bone health, and that's especially important during the bone building years of childhood and later in life, when we also know that osteopenia and osteoporosis are strongly linked to nutrition, and where we understand that calcium balance is really important for bone health. So I wanted to also emphasize the important role of nutrition. And remembering that often people think, well, I can just take a calcium supplement to boost calcium deficiency. So why do I need to think about lifestyle management? But we also know that lifestyle management can help reduce calcium loss by being physically active, not smoking, and reducing caffeine and alcohol consumption. We also know that just because someone might have a heavier body mass, that's actually not necessarily very good for actual bone loading. And so having higher body mass doesn't necessarily protect against bone demineralization and bone fractures. And it actually impairs those components of bone that give bone its strength and protect against fracture. And we also know that having excessively high body mass makes it really hard for a person to be physically active and function physically, and that they might have to physically compensate and have some abnormal body movement patterns in order to get around and be physically active. And that can actually contribute to musculoskeletal strain in the joints as well. Now, other lifestyle factors are important, as I've said. So smoking and avoiding smoking where possible is important because smoking is associated and will increase local inflammation. It can contribute to bone thinning, delayed healing, and increased pain. Poor sleep, as I've already mentioned, really can impact physical and cognitive function. We know it increases illness and injury rates, and we know that it's linked to high blood pressure and heart disease. And that we also know that poor sleep is associated with increased pain as well. And we also know that stress levels have a relationship between mental and physical health. They can reduce pain tolerance. And we know also that poor mental health is often associated with other poor lifestyle factors, such as smoking, alcohol use, or poor nutrition. And again, on this next slide, again, it's a little bit busy, but again, it's really just highlighting this interplay between lifestyle factors and how they can cause local tissue damage and local inflammation, which contribute to systemic inflammation, which feed back into lifestyle factors that can also then culminate in more systemic inflammation, which affects sleep, which impacts psychosocial factors, and all lead back, and it all creates a big mess and really feed into each other. So it's really just again reiterating that it's really by increasing exercise and improving diet, it can have impacts at lots of levels of the body, and again, not just musculoskeletal conditions. Now, what are recommendations for a healthy lifestyle? Well, the WHO, or the World Health Organization, recommend eating lots of fruit and vegetables, reducing fat, salt, and sugar intake, maintaining a healthy body mass index. And for those of you who are interested in calculating your BMI, there's lots of online calculators that can help you do this. Minimizing alcohol consumption, being physically active, and trying to not smoke. WHO also has recommendations for physical activity for people with chronic conditions, and they recommend at least 150 to 300 minutes of moderate intensity aerobic activity a week. Or if you're going to be really vigorously active, at least 75 to 150 minutes. They also recommend participating in muscle strength exercises at least 2 days a week and trying to limit the amount of time being sedentary. And that means trying to limit how much you sit still or lie down on a daily basis. Now, these recommendations can feel really daunting for people who have a painful musculoskeletal condition. And it is okay to do physical activity in bouts of just 10 minutes. And remember, as I've already pointed out from some of the evidence from osteoarthritis, as little as 45 minutes of moderate to vigorous activity a week can actually improve physical function in knee OA. So although these WHO recommendations are something, a gold standard, if you like, to aim for, a little bit of activity is better than none, and small bouts can add up to these bigger recommendations over a week. We also have more specific recommendations from the European Alliance of Rheumatology Associations, specifically for people living with rheumatic and musculoskeletal conditions. And they have a number of overarching principles where they say that lifestyle improvements should complement medical treatment. They're not a replacement. Lifestyle improvements are an essential part of musculoskeletal management and add to overall health benefits. And they reiterate that those WHO recommendations for a healthy lifestyle that I've just talked about are applicable to people with musculoskeletal conditions. Often people think, oh, well, they're only for healthy people. They don't apply to me. And also, it's important to remember that lifestyle management will be really individual for a person with musculoskeletal problems and depend a bit on factors such as age, sex, the actual health condition, and various other factors. And you should discuss regularly how lifestyle management can fit in with your health professional and your GP. But some specific recommendations for exercise are that exercise is beneficial for many health outcomes, including but not limited to just musculoskeletal symptoms and progression of the disease. But we know that research can benefit pain, function, and quality of life, and that people with musculoskeletal conditions should avoid physical inactivity and engage in exercise according to their abilities. And again, reiterating the importance of both aerobic and strengthening exercises. I think number 5 is really important because I think there's often a lot of fear in people with musculoskeletal conditions that exercise might be harmful or unsafe. And these guidelines recommend and advise that exercise is safe and that it's never too late to start exercising. And really reiterating finding the exercise that is right for you. Because exercise can be performed in different settings, either alone or in groups. It can be done self-directed at home using a program like the My Knee exercise program that I described a little while ago. And that people in particular with osteoarthritis and spondyloarthritis should especially exercise because we know it is particularly helpful for those conditions. A healthy and balanced diet is really important. And also just, I guess, a caveat in that there's really no evidence saying that one food type or a specific food diet over another will be more beneficial for musculoskeletal conditions. Because I think we often see there's often fad diets out there promoting one type of food over another and that it might be more helpful. This is just a caution that really consuming specific food diets is unlikely to have any large specific benefits for particular musculoskeletal diseases. Again, reiterating that a healthy body weight should be a goal. And for people who have overweight or obesity, should work with health professionals to help them achieve weight loss according to their individual goals. Just again, reiterate minimizing alcohol consumption but also reassuring that low levels of alcohol consumption are unlikely to negatively impact musculoskeletal conditions, except in certain situations. And you can see here that point number 3 really does point out one of those certain situations, which is where people with rheumatoid arthritis should be aware that moderate alcohol consumption could increase a risk of rheumatoid arthritis flares. And again, that same caution applies also to people with gout. Not surprisingly, people with musculoskeletal conditions should avoid smoking if possible, and people with rheumatoid arthritis in particular should be aware that smoking can affect some drugs that people might be being prescribed for RA. So just in my last few slides, I wanted to talk about how people might get started with physical activity. And walking is a really good, free, inexpensive exercise option. All you need are comfortable clothes and a decent pair of walking shoes. It's something that everybody can do. You don't have to be powering around the local oval. You can even start by walking up and down your street or around your yard if you've got a backyard or a front yard that's conducive to that. And I've already talked about, you know, the myth busting around the 10,000 steps a day. But, you know, aiming for 7,000 to 8,000 steps a day is what's recommended. But remembering as few as 6,000 steps a day, we've actually got research evidence now to show that that can reduce the risk of mortality for older adults. So again, really myth busting that very lofty goal of 10,000 steps, which I think puts a lot of people off walking. And remembering that there's lots of technology now to help people count their steps a day. Some people might have a pedometer, which is a device that you can put on a belt. These days, more people have got wrist-worn activity trackers or smartwatches, or even if you don't have those but have got a smartphone that you put in your pocket when you're walking, lots of smartphone apps can track your steps as long as you're carrying your smartphone with you. So think about how you might be able to use technology to help set goals and actually track what you're doing and help you be motivated to sticking to a walking program. What about strength exercise? There's lots of ways that you can apply resistance to your body to help strengthen your muscles. So you can use body weight, so exercising in like the squatting position that you can see there in that little infographic here. You can use free weights like what you might see if you go to the gym, but you can certainly get cuff weights to exercise at home, or use exercise elastic bands to apply resistance to leg muscles. Or again, we're seeing resistance machines there if you like to go to the gym or have access to that sort of equipment. Increasingly, some of these exercise machines are affordable at home. How often should you do strength exercise? Well, you really need to do it at least 2 days a week. And typically 1 to 3 sets with at least 8 to 12 repetitions of each exercise to appropriately stimulate your muscles so that you can get an improvement in muscle strength. If you don't push muscles enough, they won't respond and get stronger. So it's really important to be working at the right intensity. So exercise is, if you're just a beginner or an older person starting exercise, you might want to start light to, very light to light. But typically, resistance exercise should feel somewhat hard. And then you'll know that you're probably stimulating your muscles. And then over time, you gradually increase the resistance as muscles get stronger. What about if you want to be doing a bit more aerobic exercise? We've talked a little bit about walking, but there's lots of other options such as cycling, running, swimming, dancing, all sorts of sports that can have an aerobic component to them and they don't have to be competitive sports. It can be having a social hit of tennis with your partner or a friend. How much aerobic exercise should you do? Again, trying for 3 days a week. And it's important that if you're wanting to get that sort of those cardiovascular benefits of aerobic exercise, you want to be working at a moderate intensity. So that's when you're breathing harder than normal, but you can still talk to someone. If you're aiming for vigorous intensity, you would be thinking to be out of breath and you can really only say one word at a time. And so, again, we've talked a little bit about those WHO recommendations of exercise, but just as a reminder that bouts of, smaller bouts of aerobic exercise over the week can build up to, 150 minutes a week. And again, thinking to gradually progress the challenge of aerobic exercise over time. What about getting started with weight management? Because that can be really tricky, and there are a number of ways to do this. You can just look at some personal lifestyle changes that maybe that you want to make. So this is really thinking about healthy eating, thinking about portion control and what you're eating, and combining that with some more physical activity. You might think about engaging with some more formal weight loss programs or products. I mean, we see lots of them on the TV. You see them advertised in the pharmacy that can really help provide structured guidance and support with lifestyle and weight loss. And many of these now can deliver meals to home to help you with that. Or you might want to seek guidance and support from a health professional, such as a dietitian. So it's really important that you think about your weight loss goals and choose the approach that's going to work for you, that's feasible and sustainable. And often a simple way to start is to just think about healthy, balanced meals with appropriate portion sizes. A lot of people don't realise that they're often eating bigger portions that are actually recommended. And so some good guidance for this is the Australian Guide to Healthy Eating at this website. It really talks, I've just put a little picture of it here, but there's a lot of information in that guide, including about how much of different types of foods you should be eating, but also talks about portion control as well. And so it's a good place to start if you want to do some extra reading on this. And finally, I'll just point you to our website. As I said, we do osteoarthritis research, but we always try to, where possible, make the outputs of our research available. And so we often have a lot of patient resources available for people with osteoarthritis and joint pain that we make freely available. And so I've got a few here on this slide. The top one is the My Knee exercise program, which I spoke about, which is the web program with a strength exercise program and physical activity guidance for people with knee pain. We've also developed a 12-month home-based yoga program for people with hip and knee OA that they can do from the comfort of their own home, following along with videos via a yoga instructor. And the other one I'll point out to, which I think often people are looking for more information about hip and knee OA, we've developed a free education course called Taking Control of Osteoarthritis that is sort of built over 4 weekly modules that takes you through osteoarthritis and talks a bit more about physical activity and weight management in particular for that condition. So I might leave that there on the slide, Helen, because that brings me to the end of what I was going to talk about, but I'll leave that there for anybody who might be interested.
Fantastic. What an amazing Koadlow Lecture for 2024. Thank you so much, Rana. We've got a bit of time up our sleeve, and there's been some questions and conversations going on in the background. One of the things that we've certainly heard from our consumers who are engaged with MHA is that when you're living with, say, chronic pain and you find movement difficult and challenging, and you know that moving is going to cause pain, and you sit down with a healthcare professional, whether it be your GP, your rheumatologist, or your physiotherapist, and they sit there and they say to you, okay, well, what's going to be best for you is to lose weight and to start exercising. For a lot of people, that's a bridge too far, because I think, and this is just anecdotal, but I think that the way we as a society approach diet and exercise is it tends to be an all or nothing approach. So it's either you're doing absolutely nothing, and in doing nothing, you're harming your body in certain ways, or you're doing absolutely everything. You're going for kilometre walks every day, and you're going to the gym, and you're eating such a low caloric diet, and living this healthy, fantastic lifestyle. So one of the things I'm curious from your perspective, and this is a little bit of vested MHA self-interest, is what are your thoughts about taking, progressive approaches in terms of how we think about movement and exercise and changing the way that we behaviorally engage with that? So I'm going to throw on the table, what about people starting with, say, chair-based exercise?
Absolutely. I mean, we know, and essentially, you're right. People often think all or none, or they go, oh, I sit all day. I can't. We're surrounded by images of AFL players and fit, and people go, I don't fit that mold. And you're right. Having pain or having weak muscles or unstable joints creates fear. And so then I think that psychological aspect also feeds in and plays with the physical manifestations of the disease. And so it is baby steps, and that is absolutely okay. And there's evidence to show that, people can get benefits from starting small. And what we know is often, so I would be, I wouldn't be saying, okay, go and start. If someone is really anxious about that, don't start with 5 different lower limb exercises and try to build muscles in every muscle group so you look like the Hulk. Start with one muscle group and one exercise and work on that for a week or two so you don't push it. See how your joint goes. A little bit of pain is okay. It's not harmful. And so I think it's also about breaking the cycle of fear and understanding that pain doesn't necessarily equal joint damage, because I think that's the other thing that also comes into play. We also, when we think about musculoskeletal conditions, we think about bones and cartilage and joints and x-rays and think, oh my goodness, this is going to be bad. This is going to make my joint worse. I've got all these bone changes. I can't do that. We know that's not the case, but in order to actually get the confidence and learn and build capacity, it must be progressive, because there'll be nothing worse than somebody going out and doing too much and flaring up their joint so badly that they then are bedbound or can't move for weeks. That is going to ruin someone's experience of exercise and make it really hard to get anyone to engage again. I think we need to think about lifestyle management as a long-term gain, but also a long-term game. So therefore, why would we expect to do everything tomorrow? It's got to be incremental steps and mixing it up along the way, but also being kind to yourself. Musculoskeletal conditions and chronic conditions often come in those cyclical nature where there might be a bit of a flare, or we'll call it a flare, or it's a bit worsening and then it gets better. And it might be, I'm having a bad patch. I can't exercise for a week or 2, or maybe it's for a month, but I know this will settle. And when it settles, I'll go back into it. And that is okay as well. So I think people are hard on themselves and think, and so we've got to allow these smaller steps and give ourselves the ability to try things and realize that we don't need to be as fearful as perhaps we might otherwise have been. Does that answer your question?
Absolutely. And I think, Rana, that translates also to the diet side of things.
Absolutely.
Is that we seem to also have this narrative that diet means doing without, means going without, as opposed to having in our own minds and more broadly, it actually doesn't mean we have to exclude the things we love to eat and that give us enjoyment, but we have to be conscious about how much of that we eat, or
exactly.
how large the portion sizes of that we eat. And that it's not about deprivation, it's about balance. And I think that we historically struggle with that. And I think it ranges for there's a whole range of issues at play here. And it's about how, as you said, people are presented, and it's, you want to look like this or you want to look like that. Well, these are the things you have to do. You have to do, exercise 6 days a week, 2 hours a day, and you have to be eating, portions of steamed vegetables and grilled chicken. Well, I think, to my way of thinking, if you're in pain, that you'd just be sitting there and saying, I'm in pain. Now I'm going to do that to myself. Really? So,
I know. Life's already bad enough without denying yourself
precisely.
every pleasure in life. No, and you're exactly right. And, one of the things just thinking as you're talking, reflecting on our recent clinical trial where that I talked about with the dietary intervention, where in the early phases to help people lose the weight, that it was a more hardcore approach, if you like, where it was a very low energy diet with meal replacements. But once people lost their body weight, the key part was transitioning to healthy eating, because you can't live like that forever. And one of the comments that that came through in the qualitative research from people was they just didn't really understand. Well, they said, I didn't understand portion sizes, and really didn't understand actually how big portions I was serving on the plates for myself and my husband at nighttime, until you gave me a portion plate. We actually, as part of the package in that trial, it's we gave them like templates with this is a dinner plate and you should have this much and this much. And it's just simple visual things like that when people go, wow, it wasn't so much about taking this off the plate, but just reducing the portion sizes. And that's why I say it's important for different people will have higher levels of motivation and be at different stages of ready to engage with different interventions. So it's really important to reflect on you and your individual circumstances, what your goal is, where you're at. And maybe for one person, it's like, I probably can only start thinking about portion and healthy eating. So I'm going to go to that document I recognize. But other people might be going, oh, no, I'm really ready. Summer's coming. I want to lose some weight. I'm going on a cruise holiday or whatever. And it's really about tailoring the resources that are out there to where you're at any given time, not an all or none thing.
And I think this plays into that broader conversation about when people are living with musculoskeletal conditions, their lives are so impacted
Yep.
on from their ability to work, to their intimate and personal relationships, to their social and community engagement. And I think, when certainly the research that we've done as an organization, it highlights the isolation of having these types of conditions. And then to layer on top of that, oh, by the way, you can't eat this and you can't eat that. And it's one of those things, I think, because we as a society, food plays a big role in our social and personal interactions.
Absolutely.
And it's
One of the
about.
biggest challenges is often dealing with being able to go out for dinner with your friends and family. And so that was a key part of our weight management program, was because you can't say, well, you can't ever go out to dinner, but you just need to have so thinking about how, well, if I do, I'll have a look at the menu ahead of time. It's not that I'm not going to do it, but just starting to think about where people choose to eat. But yeah, we can't have an all or nothing approach, because you're right, that's going to impact people's social lives. And we've talked about mental health. We don't want that going, even becoming even more negatively impacted, because we're removing those social outlets and that really important participation.
Absolutely. Now, interestingly enough, there's Denise, one of our viewers this evening, was saying, she tried to join her local gym, but all the equipment was upstairs, and she suffers from really severe damage to her feet, that she can barely walk. Now, you've got someone
Wow.
wanting to engage in exercise, and yet, you're faced
Yeah.
with those situations. So this is also about, and a role that MHA has to play in, about that broader education
Yep.
within the healthcare profession and the fitness profession about, well, what things can be done to, and as you rightfully said, and what we've got up on the screen, there are things that can be done at home. As I said, I'm going to harp on about this, as a starting point, chair-based exercise. If you've
Yep.
got, we've just put up a series of fantastic videos that we did with the team at the University of Sydney. And I tell you what, if you have a look at them, they go from the very basic
Yep.
through to ones that very fit people would find very challenging by the end of them. And it's that incremental. Okay, so you start with something like chair-based exercise, you build some strength, you build some
Absolutely.
balance, you build some core strength, and from there, you're feeling more confident, you know what your body can do, and you start going for a walk around the block and getting that cardiovascular. So it is that it has to be, I think, as you rightfully pointed out, what suits you, where you're
Mm.
at, and what you're living with, but also it doesn't have to be that all or nothing. You can actually
Yep.
build up over time, and that's a good thing as well. Now,
Exactly.
one of the questions that has arisen in the chat is, how do we, musculoskeletal health as a general area of health has not gotten the same priority, the same spotlight as other chronic health conditions such as diabetes or cardiovascular disease. And as such, I think that preventative or good musculoskeletal health approach hasn't had the focus it really should have. So everything we've been talking about here, I know we've had a focus on particularly OA and knee OA and the diseases themselves that fall under that banner. But what sort of things should we be doing, I imagine, from a very early age to ensure we have good musculoskeletal health?
Look, I think, so much about behavior, if we think about behavioral theory, so much about behavior is trying to turn things into, an automated habit, if you like. So as much as we can make things build healthy habits, and this is where we need to be doing that with our kids. I'd say, so there's many arguments for all sorts of things that we should be doing, but building healthy habits for exercise and really being a lifelong exerciser. And recognizing the variety of exercises and physical activities that are out there. That there's a spectrum from, different, I've got yoga on the screen here, which might suit one person, whereas strengthening suits another. So I think that's something that we need to be doing from an early age. That's something that, we need public health awareness campaigns around that. So families are encouraging that with their children, but we obviously have ready audiences in schools. And I don't think we're probably doing enough in that space. The education system would argue that there's so much getting packed into schools and, trying to build and maintain physical activity. I think we do it well in primary school, but particularly in secondary school and particularly in girls. That's when we know in those adolescent years that sports and physical activity and exercise participation can drop off. Often particularly because people are self-conscious and there's those confidence issues. So we need to think about broadly around, as you've talked about already, with, the person who can't get upstairs with their musculoskeletal condition. But we also need to think about those gym environments. Are they really welcoming to people, young people and females and people of different cultural backgrounds? Because we need to be getting, we're a very multicultural society here in Australia. Again, I'm focusing on exercise, but diet and nutrition go with that. I mean, I would love to see academics in schools, not just about academic stuff, but actually about good health and good nutrition and how to do that for yourself. I mean, back when I went to school, we had cooking classes and stuff, but, so many people don't know how to prepare a healthy meal these days anymore. And, it's got to be something that's taught from a young age, and it needs multiple players really need to value this and embed it so it does become a habit. And so as people are getting older and going into adulthood, these healthy habits and habits of exercise are embedded into us all.
I just want to touch on a couple more things with you. Now, you highlighted in the lifestyle factors that have influence, sleep and stress. Now, how do they also interplay with diet and exercise? I imagine these are not silos that you just address one at a time. I imagine there's quite an interplay in amongst.
There is, there is. And it's not necessarily what I would call a unidirectional relationship either, because, in many ways we used to think, oh, well, it's having body pain is what causes you to sleep badly at night. Well, now we also know it's a bit the other way as well, that if you've got poor sleep hygiene or, poor sleep habits, that actually can lead to, a poorer tolerance of pain and can actually exacerbate those feelings of pain. And the same thing can happen between mental health and stress levels. And so, yes, then they're all related, because if I've had poor sleep, I'm then going to get up feeling really fatigued. And then the last thing I want to do is go for a walk around the block. So then I'm going to sit on the couch, and then, well, maybe I can't even be bothered cooking a meal. So I'm going to eat something that's not quite the healthiest meal. And then all of a sudden we see how it's all interrelated. My joint pain's worse. And well, then we're in one of those vicious cycles I've put up on one of the slides before. So yes, they are all interrelated. And often feeding into and back and forward to each other as well. So breaking the cycle can really help to turn things into a more positive loop rather than a negative loop.
Oh, look, and I'll admit, Rana, I'm incredibly guilty of when stress levels get to a point, and you just sort of, and I'm sure you do it as well, you sort of think,
Absolutely.
I don't want to cook tonight. So
Yeah.
on the way home, I'll get a dirty takeaway, and I'll sit in front
That was
of
me yesterday, Helen.
the television, and I'll just enjoy myself. And as you said, and usually you do that and you have a terrible night's sleep, and
Yep.
and so you start that cyclical effect. You're absolutely right. Look, one of our viewers this evening, Caroline, has raised something around, specifically around her situation. Now, I know you can't address specific issues and conditions, but I just want to, what she's mentioned is she has severe osteoporosis, and she's had several spinal compression fractures, and she does have a fear of having another fracture. And, particularly if she engages in exercises or, overdoes it. So, someone with these sorts of, in this sort of situation, where do you think it would be a good starting point to engage with that movement and exercise?
I think in that sort of example, I wouldn't be probably wanting to do, I mean, obviously, I think I can't comment on balance and whether there's any falls risk there, but I mean, obviously, walking is always going to be a low impact, low risk activity. But when someone's concerned and had those sorts of fractures, I think the best way and the safest way, and also the way to build confidence, is to see a health professional and get a program that's individually prescribed and can be monitored. And so you've got that source of support to go back to if there's any problems. And so finding, it might be that it's a GP, it might be that you have a physiotherapist that you trust, it might be an exercise physiologist, but consulting and getting a program that's just right for you and under the guidance of a qualified health professional is probably a good way to go.
And I want to talk a little bit more about that, Rana, because you've made a really good point. Is that, and obviously what Musculoskeletal Health Australia is focused on is empowering the consumer, empowering the patient to have the knowledge and the support and the services and the ability to lead their own musculoskeletal health journey and have control over what they engage with, how they engage with it, when they engage with it, and that self-care and self-empowerment and self-efficacy. And what you've raised there is the importance of that multidisciplinary team, because in the musculoskeletal space, that is so important. And when I highlight that, I'm also, you're absolutely right, your GP, absolutely, your specialist, your rheumatologist, but also physiotherapists, exercise physiologists. We would even put pharmacists in there, having a really good relationship with your community pharmacist and being able to talk to your community pharmacist and understand what medications you might be on and how they might impact you or what exactly they're doing. But that's so important. So I'm going to throw out a bit of a curveball for you as we're winding up. But how do you think we have a healthcare profession, particularly in certain areas, where a lot of the healthcare professionals aren't actually that au fait with dealing with an informed consumer. So dealing with a patient who actually comes in and has knowledge and asks questions. How do we go about having a bit of a cultural change within the healthcare profession to say, actually, you're part of a team, and really the leader of that team is the consumer themselves,
Yeah.
because it's their condition.
Yeah, look, I think it's an interesting point. I think it's one of those things that will take a lot of time to change. You know, what you say makes me reflect back on, you know, my undergraduate training as a physio, and certainly these concepts of person-centered care. You know, the patient at the centre of the healthcare team was not something that was common. It's certainly changing now. I look at what, you know, I'm at the University of Melbourne, so I'm in the physiotherapy department there, and I also know what goes on over in the medical degree as well that's taught there, and it's very much taught differently. So I think the emerging health and medical workforce will be changing, and will be expecting an informed consumer. So in many ways, I think we need to, as when encountering health professionals, I think it's a bit of the consumer or the patient will have to educate you know, really bring those health professionals along on a journey. And remembering, I guess I would always say, if you're encountering someone who's resistant, ultimately you choose your healthcare provider. You should be working with a team of professionals who you're comfortable with and confident with, and have that relationship with. And if you're not getting that, look elsewhere. But as I said, I think contemporary healthcare training is changing, but it will take time. It will take time.
One final note from one of our viewers this evening said, let's not forget about hydro exercise base. So
absolutely, yep.
that you can still do that in water, and so that's another build up option. Start with doing some
yes, yep.
water-based exercise, and
then move to the land. Exactly.
Absolutely.
And so
that's fantastic.
often really helpful for people who might feel like their joints are unstable, or they're particularly weak, or who are particularly worried about, you know, standing or weight bearing. Starting with a program of sort of aquatic exercise, and lots of the gyms and places around will have you know, they're often termed arthritis classes, just because you know, they don't use the word musculoskeletal, but you can find lots of those classes around, which can be a really nice, gentle introduction to starting to be physically active.
Wonderful. All right. Look, Rana, on behalf of Musculoskeletal Australia, I would like to thank you for delivering such an insightful and informative Koadlow lecture this evening. I've really, really enjoyed talking with you post the lecture and learning more. And I think all of our those who attended this evening will absolutely agree with me. But before we finish tonight, I would like to draw everyone's attention to an amazing initiative that forms part of Musculoskeletal Health Australia's Awareness Month. And that's the world's biggest sit-in, proudly brought to you by EpiJoint, to be held on Thursday, the 31st of October. Now, we're asking everyone to join us in our attempt to break the world record for the largest chair-based exercise class ever held, as well as helping us raise funds to support the work we do here at MHA. I encourage everyone to write their names in the history books and register to participate in WBSI. Join us and our incredible instructor, former gladiator and the Biggest Loser trainer, Tiffany Hall, who is leading the world record attempt at the Ripponlea Estate at Elsternwick in Melbourne. For others of you from around the country, there are several ways you can join us as well. So if you head to our website, wbsi.org.au, or scan the QR code on the screen and register now. So that brings us to the end of the 2024 Koadlow Lecture. Rana, I once again want to thank you for an amazing lecture. And to our sponsors this evening, Peninsula Hot Springs and AbbVie. So on that note, I'm going to say I look forward to seeing you all on the 31st of October when we break the world record at the world's biggest sit-in. Thank you for joining us tonight. And Rana, thank you once again.
Thanks for having me, and thanks for coming along, everybody. Good night.